Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hello everyone, I am Angela Lamarca, consultant medical oncologist at Fundación Jiménez Díaz University Hospital in Madrid, Spain, and I welcome everyone to this program titled Immunotherapy for Hepatocellular Carcinoma, Navigating the Dynamic Treatment Landscape. Please allow me to welcome two experts in the field, Lorenza Rimarsa, Associate Professor in Medical Oncology in Milan, Italy, and Riyad Salim, Professor of Radiology in Chicago, USA. In this activity, we are going to discuss the role of immunotherapy in HCC at all stages of the disease. We will start with a patient case example in advanced HCC, and we will later on move to examine the clinical implications of the latest data on immunotherapy in intermediate stage HCC. Finally, we will move into early stage and discuss immunotherapy in the adjuvant setting. Let's start with immunotherapy for advanced hepatocellular carcinoma. Lorenza is going to present the case discussion. Lorenza, please proceed.
Thank you, Angela. Hello, everyone. So the case is about a 75-year-old lady that presented in October 2018 with bilobar HCC nodules seen in the CT scan and MRI. The largest in segment 2, 21 millimeters, and in segment 8, 6, 13 millimeters. In terms of comorbidities, the patient had a hypothyroidism, GERD, and importantly for the HCC in 1996, the patient was diagnosed with HCV-related chronic liver disease and treated with interferon, peginterferon, and ribavirin without response. Then, in 2016, the patient was treated with DAAs with SVR. So starting from the beginning, the patient had no family history of cancer, no smoking, no alcohol use, no allergies, and underwent several local regional therapies, starting from April 2017 to June 2018. RFA, microwave ablation, TACE, again RFA, and again microwave ablation. Then there was a multidisciplinary team discussion. The patient had well-compensated liver cirrhosis, child-Pugh A, ECO performance status 0, and the stage was BCLC-B, so liver-limited disease. Considering the number of local regional therapies already received, the MDT decided for systemic treatment, and the patient underwent a liver biopsy to confirm the histological diagnosis of HCC.
Thank you very much, Lorenza. So we're taking into account this case. Which are the immunotherapy-based treatment options that you think we could consider, and which is the clinical data supporting these alternatives?
We now have two immunotherapy combinations approved, let's say, worldwide, atezolizumab plus bevacizumab and durvalumab plus tremelimumab according to the STRIDE regimen. Starting from atezolizumab plus bevacizumab, the IMbrave 150 was the phase 3 trial that demonstrated the superiority of this combination compared to sorafenib, that was the standard of care at that time. Atezolizumab plus bevacizumab is superior compared to sorafenib in all the efficacy endpoints, from overall survival to progression-free survival and response rate. And importantly, in terms of safety, the treatment is quite well tolerated, with hypertension being the most frequently observed adverse events. It's important to mention that the most worrisome potential adverse event associated with the bevacizumab was the bleeding, or the risk of bleeding from esophageal varices in patients with HCC and liver cirrhosis. So all the patients had to receive an upper endoscopy and treatment of varices observed before starting treatment. And with that, the percentage of patients who had bleeding events or grade 3-4 bleeding events was similar in the atezolizumab arm and sorafenib arm. And also, importantly, in the trial, the time to deterioration in quality of life was longer with atezolizumab plus bevacizumab compared to sorafenib. So we have a combination that was superior compared to sorafenib with a good safety profile and good quality of life. The second positive phase 3 trial is the Himalaya trial that tested the combination of a single priming dose of tremelimumab followed by durvalumab, the STRIDE regimen, versus sorafenib, and also included a durvalumab single-agent arm that was tested for non-inferiority versus sorafenib. The trial showed that STRIDE was able to achieve a longer overall survival compared to sorafenib, and durvalumab was non-inferior compared to sorafenib in terms of overall survival. There is no benefit in progression-free survival. This is something that we are learning to see with the double immunotherapy combination in the HCC, and there is a benefit in response rate. In terms of safety, the combination is very well tolerated, and the percentage of patients who required high-dose steroids to manage the immune-mediated adverse events is 20%. That is quite low considering the double immunotherapy combination. Importantly, recent data presented at ESMO 2024 showed that the overall survival at 5 years, and approximately 20% of the patients in the STRIDE arm are alive at 5 years, and these are unprecedented data in our resectable HCC. So we have two immunotherapy combinations that can be chosen, can be evaluated for this patient.
And with all this in mind and all this data that you presented, Lorenza, how can we make a decision in our clinic? Which are the factors that we can use for selecting immunotherapy for our patients?
This is a very important question with a difficult answer because there are some differences in the trial. For instance, in the Himalaya trial, patients with a main portal vein thrombosis were not included, so patients with the BP4. All the other types of portal vein thrombosis were included. And of course, for patients with a high risk of bleeding, bevacizumab is not an option. But if you consider baseline characteristics like the liver function, the etiology of the disease, meaning viral HCV, HBV, or non-viral alcohol or metabolic, or other baseline characteristics or baseline factors, actually, there is no way to select one treatment or the other. So I think we should consider which are the comorbidities of the patients, for instance, prior bleeding events or risk of bleedings, cardiovascular diseases, autoimmune disorders, for instance, prior liver transplant. And some of these comorbidities can be a contraindication for a combination. For instance, high risk of bleeding or severe cardiovascular disease can be a contraindication for bevacizumab. Other comorbidities like severe autoimmune disorders can be a contraindication for both. And so based on the clinical characteristics, we can try to select which is the best option for each patient. Unfortunately, we don't have any biomarker that can help select which is the best regimen. So based on baseline characteristics and the safety profile of the two regimens, I think we can try to decide which is the best option for each patient in clinical practice.
Yeah, absolutely. It's definitely a very challenging decision in our daily practice. Hopefully, we will have a biomarker at some point in the coming future. And once we have started the treatment, which is the toxicity profile and what can we expect with these immunotherapy-based combinations?
Yeah, from the atezolizumab plus bevacizumab combination, we can have immune-mediated adverse events, and we can have adverse events associated with bevacizumab. For bevacizumab, as mentioned, hypertension is the most frequently observed adverse event and can be easily managed in clinical practice. Then we can have proteinuria that can be an issue in patients with liver cirrhosis. And as mentioned, the bleeding can be an important adverse event, can be a serious adverse event, especially from esophageal varices. For atezolizumab and also for durvalumab plus tremelimumab, we have the immune-mediated adverse events that can include a liver toxicity that can be concerning and should be assessed. We can have other immune-mediated adverse events like a hypothyroidism, for instance, that is very frequently but very easily to manage with levothyroxine. We can have other immune-mediated adverse events like skin toxicity or colitis, for instance. And depending on the severity of this adverse event, we have to interrupt, or more rarely, we have to discontinue the treatment. The percentage of patients who require steroids to manage the immune-mediated adverse events is lower with atezolizumab, considering the single immunotherapy agent. But in a way, it's not so high also with durvalumab plus tremelimumab. So in the end, we have immune-mediated adverse events and the events associated with bevacizumab in the atezolizumab plus bevacizumab combination.
Thank you very much. It's a fantastic overview of everything that is happening with immunotherapy and systemic therapies for advanced HCC. But Ria, do we still have a role for local regional therapies? Can you please let us know, how do you see the local regional therapies for advanced HCC?
Yeah, so this is an interesting case. I mean, this is technically a patient that is still, by definition, BCLC-B, but because of aggressive biology, new lesions appearing every few months, being treated with ablation or embolization, it really fits into sort of the more aggressive and worse sides of the BCLC-B that is basically managed, as you're implying, Angela, as an advanced HCC. So I agree with that because it appears that the biology is speaking to us and they need systemic therapy. Now, you ask, is there a role for local regional therapy in this case? And I would say to that, it sort of depends. I agree that given this presentation, it's time for systemic therapy. And Lorenza really very elegantly and eloquently described the choices we have. And this is level 1 evidence shown to improve overall survival. And so this is clearly the way to go. Is there a role? There may be a role if there is an element of toxicity that is difficult to manage for the patient, and there needs to be some sort of holiday or a break, and there's still some lesions that are still progressing. There may still be a role for local regional therapy in a holiday period. There may be some lesions that respond to systemic therapy, but 1 or 2 that genetically, biologically are not responding, that may need to be embolized or ablated, because this is a trend that we are observing more and more now, which is patients are responding very well to systemic therapy, but 1 or 2 lesions sort of breaks through, and you don't want to declare progressive disease here unnecessarily if 95% of the disease is well controlled, because patients are tolerating these therapies well. So there are some times when in advanced HCC, or at least in this scenario, where local regional therapy would clearly complement the systemic therapy and hopefully continue to improve the patient's overall survival.
Thank you very much. And looking into the future, Lorenza just summarized all these data with atezolizumab and bevacizumab, and also durvalumab and tremelimumab, which are now approved and available in our clinics. But Lorenza, how is the future looking? Are we coming more combination options that may look promising for advanced HCC?
Yes, there are other combinations. At ASCO 2024 and ESMO 2024, the results of the phase 3 CheckMate 90W trial were presented. And in this trial, the combination of ipilimumab plus nivolumab, so again, anti-CTLA-4 plus anti-PD-1, was tested versus a tyrosine kinase inhibitor control arm, either lenvatinib or sorafenib, and most of the patients, 85% of the patients in the control arm received lenvatinib. So this is this trial is mostly versus lenvatinib and not versus sorafenib, the other that I mentioned. And the trial is positive. There is a longer overall survival with the ipi-nivo combination versus lenvatinib, let's say, with more than 23 months median overall survival. There is no benefit in progression-free survival, as mentioned, for this trial regimen. So this is probably related to the double immunotherapy combination in HCC. There is a high response rate and a long duration of response. So very good results in terms of efficacy. And in terms of safety, the percentage of patients who require the high dose of steroids to manage the immune-mediated adverse events is around 30%. There is a benefit in quality of life. So the time to deterioration in quality of life is longer with immunotherapy compared to tyrosine kinase inhibitor. So this will likely be a new option in the treatment scenario for patients with unresectable or unsuitable for local regional therapies, HCC. And also we have the CARSA 310, that is another phase 3 trial run mostly in an Asian population, and tested camrelizumab plus rivosiranib or apatinib as small molecules against VEGF receptor 2 and versus sorafenib, and the trial is positive. So it is possible that this will be another combination available in the future, even if considering the enrolled population, 83% of the patients from Asia, we will see if this will be available in Western countries or not. It is already approved in China. And also we will have some immunotherapy monotherapy options like durvalumab, a single agent, or tislelizumab, a single agent, that it is possible that will be available for patients maybe unsuitable for combination treatment in the future. So yes, we will have other immunotherapy regimens that will be available for our patients in the near future.
Yeah, definitely. And this is fantastic news because advanced ACC has been really very poorly covered by new treatment options for many, many years. And now over the last years, we have seen a really rapidly increasing number of combinations and immunotherapy approaches coming. So really a huge unmet need that we are really, really treating much better. And we see, I think, that benefit in our daily practice. Let's move into another one of the topics. We have already spoken about immunotherapy for advanced HCC, but let's now move into intermediate stage. So Riyad, can you please summarize a little bit for us intermediate HCC and the current treatments that we have available in the field?
Yeah, thanks, Angela. So you can see here from this slide the most updated and contemporary BCLC algorithm that has subdivided intermediate disease now into 3 categories. We've already referenced one, the case that Lorenza already showed, was sort of a more aggressive BCLC-B on near the advanced side, and that was treated with systemic therapy. And then there are those that are just outside of transplant criteria, those that are beyond Milan criteria or other types of criteria that can be treated, that are intermediate and can be treated to downstage to transplant. And then those in between are those that are treated in a palliative setting and sometimes even in a curative setting with the standard of care treatment. Now, those treatments currently are chemoembolization. That is the worldwide gold standard based on 2 randomized clinical trials comparing chemoembolization to placebo, both published in 2002, and both demonstrated an improvement in overall survival. And since then, there have been advancements in TACE with some treatments and addition of TKIs, for example, and other types of agents tested alongside, with improvement in, say, time to alternate therapies, time to hepatic decompensation. No study really has improved overall survival in chemoembolization. And currently, in the best of hands, median overall survival is about 25 to 30 months in this patient population. The other therapy that is really emerging now very rapidly as equivalent and in some cases superior to chemoembolization is TARE, radioembolization, or SIRT, where in a manner analogous to TACE, radioactive microspheres are injected in the hypervascular tumors, and because of the high dose radiotherapy, the response rate in general appears to be higher than chemoembolization. The TTP appears to be longer. The deterioration in quality of life appears to be less. In other words, it can be done on an outpatient basis with better treatments. And some early studies now showing potentially now even an improvement in overall survival. You know, we are in a very complex field now where everybody trying to do survival studies in this area are confounded by subsequent therapies and the therapies that Lorenza was talking about. So we're really in the imaging endpoints. But the 2 standards currently globally are chemoembolization and radioembolization. Now, radiotherapy, external radiotherapy has a place as well. There are many places with expertise that are continuing to study that in this space. So I want to certainly make sure that I recognize that. In some rare instances, there's some ablations that are done and some combination treatments that are done and some emerging ablative type therapies. But in general, currently, the global gold standard is chemoembolization and rapidly rapidly catching up and in many cases exceeding outcomes is radioembolization.
Thank you very much. And I think with everything we have seen of what is happening in the advanced setting, it makes sense to ask the question of why don't we combine both, all these treatment options that you were discussing in local regional with immunotherapy. And we know that there could be a rationale for this. Actually, we can use the local effect of the local regional therapies to convert cold tumors into hot tumors where immunotherapy may work better, and affecting microenvironment again to try and boost the effect of immune activation by our immunotherapy treatments. And therefore combination of immunotherapy and local regional therapies could actually have a synergistic effect. And we are already seeing some preliminary data and some data from randomized studies also supporting these combinations. So Lorenza, can you please summarize for us some of the latest clinical trial data, phase 3 studies in this setting?
Yes, Angela, thank you. The two phase 3 trials that have been presented are the EMERALD-1 and the LEAP-012 trial. The EMERALD-1 tested in patients with intermediate HCC or also minor vascular invasion, so approximately intermediate HCC, the combination of TACE plus durvalumab plus bevacizumab, and patients could have received a maximum of 4 rounds of TACE in combination with durvalumab, and bevacizumab was added for safety reasons after the completion of the TACE procedures. And this trial showed a benefit in progression-free survival. That was the primary endpoint of the study. That was almost doubled in the combination arm, TACE plus immunotherapy combination. The safety profile, of course, is different in the combination arm because we have the adverse events associated with the systemic therapy versus the TACE alone arm, but there is no, let's say, synergistic adverse events. So we saw the adverse events that we expect from TACE and from systemic therapy. We don't have overall survival data because they are not yet mature, so we will see them in the future. What we have together with the progression-free survival is also a benefit in response rate with the combination treatment. So we will see if these results will be confirmed with a longer follow-up, and if we will have positive results in terms of overall survival. The LEAP-012 is another phase 3 trial that tested the combination of TACE plus lenvatinib plus pembrolizumab, again versus TACE alone in intermediate stage HCC. And also this trial had as primary endpoint the progression-free survival, and there is a benefit in progression-free survival with TACE plus systemic therapy versus TACE. So both of these trials are positive, and this is really important because in the past we had trials that combine TACE plus tyrosine kinase inhibitors and were negative. So these are positive results, and waiting for, let's say, more mature data, we will likely have these options in the future in clinical practice for our patients.
Thank you very much. And there are two topics that I would like to bring up, because when we are discussing about these trials, TACE is something that we always say is very dependent on the center and the MDT, the discussions about re-TACE and how many TACE should we do. So Riyad, how much of importance do you think having some homogeneous practice on TACE is when we are really bringing this into practice?
Yes, of course. The concept of standardization is a very important one, and trying to do that in chemoembolization and radioembolization is a guiding principle, and to the best of our ability, this is something we need to be thinking about. There are some challenges, though, with anything that is technical, surgical, where there is going to be some element of expertise, but we certainly are moving towards an element of standardizing dosage, number of treatments, with some principles that are important for everyone to recognize. One of them being not to overembolize somebody at risk of hepatic decompensation and liver failure in order to not be able to become candidates for the systemic therapies that Lorenza has been talking about. So the last thing you want to do in your attempt to benefit from TACE or TARE is to create hepatic decompensation and then unable to receive systemic therapy. There are cases where 1, 2, and 3 embolizations are not working, and proper discussion in MDT about when the right time is to convert someone from local, regional to systemic therapy is an important discussion. So all of that, gets into the MDT discussion, into standardization, into making sure that whatever is done in Italy and in Spain and in the United States is as close to standardized as possible, because I think that's the way we get to optimizing and individualizing patient treatment.
Thank you. And my second question here, Lorenza, this one goes for you, is about how important is it to really have this overall survival benefit in the intermediate stage? We heard from Riyad previously that after all these local regional therapies, the systemic therapy will come for advanced stage. So do you think progression-free survival benefit is sufficient?
Thank you, Angela. This is an important and difficult question. Maybe in this field, progression-free survival could be enough. What I would like to see probably is at least a trend in overall survival and a longer follow-up compared to what we have now. But it's a new field because, as I said, we didn't have in the past positive phase 3 trial of immunotherapy or systemic therapy combination with a local regional therapy combination in intermediate HCC. So probably progression-free survival will be the endpoint for these trials, but I'm not so sure. I don't have yet a precise answer to your question.
Yeah, no, I agree. I think PFS is at least a guidance of the fact that the treatment is having a clinical benefit. And if these were making it to our clinic, that we hopefully will have them available at some point, I think everyone is quite optimistic about it. How do you think it will really look like? How are our patients going to be affected? Who are going to be the patients that we are going to treat with this combination of local, regional, and systemic therapy?
But I think that patients with the intermediate stage HCC, as Riyad very well described, are very heterogeneous. We have patients who do very well with a local regional therapy alone, and we have patients that we know that do need systemic therapy because they are very high risk of progression or very diffuse disease. But there are patients with intermediate stage HCC that can benefit from local regional therapies, but I think that with the systemic therapies, we can improve their outcome, as shown in the trials. So we will have to learn to select which are the patients that might benefit more from the combination treatment. But I think that patients with, let's say, a still suitable, with a disease that is still suitable for local regional therapies, but with a high risk of disease progression, those are the patients who might benefit from the combination. But maybe, Riyad, you can tell us what you think about this combination, which are the patients who can benefit more in clinical practice.
Yeah, I mean, this is a very critical question. I mean, we're still continuing to learn about this patient population based on Emerald and LEAP. So we are going to study that, and as we see the data come out, the manuscripts with all of the detail, I think it's going to be very important. In general, those that are relegated to embolic type therapies might be the ones you would consider for the combination with, again, Len-Pem or Durva-Bev. One thing that I think I have learned from these data is that, as Lorenza mentioned, there's no added toxicity or adverse event profile, which I think is very reassuring for us. We sort of have seen that clinically, but to now see that in formal clinical trials, robust studies, is very reassuring that this combination or these types of combinations is really the way to go. And it really gets back to what we have, I think, all thought for a long time, is treating the patient at the right time with the treatment and then converting when necessary. And now utilizing, the advantages of the local therapies and the systemic therapies is really the trend. And I think many of these patients are going to move that way. One other thing I would add is, because I think the patients are tolerating a lot of these therapies, particularly the systemic ones, very well, we are now even sometimes seeing a right to left shift where the patients even tolerate more local regional therapies after good response to systemic therapy. So these trials really allow us to be creative in how we treat patients, and again, ultimately individualize our treatment plans and not be so dogmatic, which has been, I think, a limitation historically.
Absolutely. So thank you, both of you. That was a fantastic discussion on the intermediate stage, which is becoming really exciting. Let's now move into early stage hepatocellular carcinoma. And in here, Riyad, we have other options of local therapies. Can you please let us know how does this look at the moment?
Sure. So now that you are in the early HCC, we are in the curative realm. And those are patients that are expected to do exceptionally well. And those are patients that we can resect. So resection, those have good liver function, good performance status, good future liver remnant are considered for resection. Those with smaller lesions, more controlled lesions, are ablated with microwave or RFA. And of course, liver transplantation, something that deals and addresses both the abnormal liver, the liver parenchyma, and the disease itself, the cancer itself, is interesting. And is a standard of care treatment. What is a new addition to this BCLC algorithm is the clinical decision making. I think everything you've heard today is about clinical decision making, and again, trying to individualize care. And what has been added to the early setting here is, if you are not candidate for those, is the benefit of the local regional therapies. You sort of stage migrate in treatment and go to chemoembolization or radioembolization in a patient population where we're targeting a potential cure.
And again, we have been speaking about immunotherapy quite a lot, so it could make sense to include immunotherapy in the adjuvant or the neoadjuvant setting in this earlier stage HCC. And again, we have had some data presented. So Lorenza, maybe you can summarize for us, what do we know about immunotherapy in this earlier stage?
Thank you, Angela. What we know is that we have a phase 3 trial in the adjuvant setting, and we have phase 1-2 trials in the neoadjuvant. So to start from the neoadjuvant, we don't have data that can be translated in clinical practice yet, but what we know is that the treatment, the immunotherapy administered before surgery can change the tumor immune microenvironment, and this can maybe with further studies, we can show if this can translate in overall survival or benefit or relapse-free survival benefit after surgery. So the point is administering immunotherapy before surgery is to activate the immune system against the tumor when the tumor is still in place, and then have the benefit after surgery. As I was saying, in the adjuvant setting, we already have a phase 3 trial, that is the IMbrave 050 trial, that tested in patients who underwent surgery or ablation with curative intent and had high-risk features. These patients received atezolizumab plus bevacizumab in the adjuvant setting for 1 year, or active surveillance, that is the current standard of care. The primary endpoint of the trial was a relapse-free survival, and the trial met the relapse-free survival primary endpoint, so it's considered positive, and the trial is published. But at ESMO 2024, data with a longer follow-up were presented, and unfortunately for our patients, with a longer follow-up, there is no longer the benefit in relapse-free survival. The overall survival data are not yet mature, but of course, since we don't have a relapse-free survival benefit, we will not have overall survival benefit. So now we don't have options in clinical practice for patients with early stage HCC, but there are ongoing trials and with other immunotherapy options, either immunotherapy as a single agent or immunotherapy combination. So we will see in the future if we will have immunotherapy options also in early stage HCC.
Yeah, I absolutely think we have to wait for the ongoing clinical trials. There are multiple combinations being tested in the neoadjuvant and adjuvant setting, and I think it will really be very important to wait for those results. And even if the adjuvant studies are negative, I still think that exploring the neoadjuvant could make a lot of sense, because we see in other cancers as well that neoadjuvant immunotherapy may have much more of an effect than the adjuvant immunotherapy in cancers where immunotherapy is also used in the advanced setting. I think we are very clearly showing how HCC is a multidisciplinary malignancy where our MDT is really very, very important, and multidisciplinary management of HCC is really the core. As we saw, immunotherapy, systemic therapies, joined with local regional strategies are now the standard of care for a lot of our patients, and these combination treatments are going to be really, really the future. And with this in mind, I would like to thank both Lorenz and Riyad for this fantastic discussion, and everyone for joining and participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you, everyone.
This program was presented by Medscape Education Global.